Good morning, ladies and gentlemen. I'm happy to be here with you. Sorry I could not attend in person this first UAE Parkinson disease and movement disorders meeting organized by Dr. Zakaria. Thank you so much, Dr. Zakaria, for inviting me to speak about Parkinson disease update. I'm going to talk about sorry, this is my disclosures. And so this is a summary of my talk. So I'm going to start with epidemiology, then mechanism and pathophysiology, then diagnosis, screening and prevention, then management, and I will finish by a couple of take-home messages. So what about epidemiology? Definitely all the Parkinson's disease experts are wondering if we are going toward a PD kind of pandemic. Of course, it's not a communicable disease, but we have definitely a higher and higher incidence and prevalence of Parkinson's disease. So it can be explained by several factors. So here you have the prevalence of Parkinson's disease. So you can see that it's mostly increasing with age, but you can have also some early onset Parkinson's disease, and especially in UAE, due to some genetic factors. I will get into the detail later on. And here you have the incidence. So roughly the incidence is 5 to more than 35 per 100,000 yearly. So this is a disease that usually occurs at around 58, something like that. It's rare before 50 years of age. It's called juvenile Parkinson's disease before 40 years of age. But actually, the incidence increases 5 to 10-fold from the 6th to 9th decade of life. And finally, the global prevalence is 0.3%, knowing that above 80 years of age, it's 3%. So initially, the mortality is not increased, but it's increasing thereafter, eventually doubling. So with the improvement in healthcare, it means longer survival. It means that the prevalence is increasing over time. Here, it was a prevalence in the 90s. Here, the prevalence in 2015, and this is the expected prevalence in 2040, actually. And this is the reason why we talk now about a pandemic. So actually, the number of people with PD is expected to double between 2005 and 2030. So years lived with disability and disability-adjusted life years due to PD increased again between 1990 and 2010. So, and also you have to keep in mind that PD is twice as common in men than in women for possibly hormonal factors, but it's still debated. So the epidemiology, again, it's a Parkinson's disease is a mix of genetic and environmental factors. So you have several types of Parkinson's disease, actually. You have the sporadic one, which is the most common one, 90 to 95% of patients. You have the hereditary Parkinson's disease, which is between 5 and 10% of patients, and probably much more in UAE due to the consanguinity, which a higher frequency of early onset and juvenile onset of Parkinson's disease. I have many patients that started their Parkinson's disease at the age of roughly 30, 35. While the pure environmental Parkinson's disease, only environmental toxic factors with no influence of genetic is still debated, and we don't know if it's a reality or a myth, actually. So as you can observe here you have the genetic factors, here you have the environmental factors. So you have to make the part between the sporadic Parkinson's disease, which is genetic susceptibility mixed with environmental factors such as pesticides and solvents, and the real hereditary Parkinson's disease, which consists of a single genetic mutation. So there are causating mutations that can give hereditary Parkinson's disease, but you have also at-risk mutation, but most of the time genetic susceptibility. It means SNPs, several SNPs that can give you a higher risk of Parkinson's disease. So smoking and caffeine and physical activity, it lowers the risk. So again, pesticides and solvents higher the risk, increase the risk. And again, here you ask risk variance in genetic risk variance. That's what I call genetic susceptibility. causative mutation, and you, of course, have epigenetic factors. We don't know exactly how it works. So now the neuropathology, to have a definitive diagnosis of Parkinson's disease, you have two mandatory neuropathologies. One, it's a neuronal loss in substantia nigra pars compacta. Here it's normal, and there is a depigmentation because the dopaminergic neurons of the substantia nigra actually co-localize with melanin pigments actually. And you have also a second criteria, which are intracellular proteins accumulation, which are called Lewy bodies. And here you have different variation of Lewy bodies. So at the early stage of Parkinson's disease, you have a loss of dopaminergic neuron, which is only restricted to the substantia nigra pars compacta, and there is a relative sparing of other midbrain dopaminergic region. And also you have to keep in mind that when you have the first motor symptoms of Parkinson's disease, when you have the diagnosis, you have already lost 70 to 80% of dopaminergic neurons. It means that the degeneration of dopaminergic neuron, it starts much earlier than the onset of motor symptoms, and sometimes 15 to 20 years before. So it means that there is before the diagnosis, there is a very long prodromal phase actually, and we're going to come back on it later on. So also to keep in mind that then it starts here, and then there is a spreading. The Lewy body pathology initially occurs in cholinergic and monoaminergic brainstem neuron, and in neuron in the olfactory system. But later on, it spreads from back to front, and from below to above. And finally, you have also Lewy bodies in limbic and neocortical brain regions with disease progression. This is what is called Braak stages. It has been supposed and assumed by Braak as Braak stages from one, only limited dopaminergic denervation in the pars compacta substantia nigra, to late stage 5 and 6 with some Lewy body in the cortex actually. And also to keep in mind that Parkinson's disease is not only a disease of dopamine actually. You have many other transmitters that are affected, like serotonin, like acetylcholine, like noradrenaline, and all this deficiency, neurotransmitter deficiency, can give some specific symptoms. So hereditary Parkinson's disease helps understand the mechanism actually. So again, I remind you that hereditary Parkinson's disease, I mean, causative mutation is only 5 to 10% of all cases, probably more in UAE. And now we have identified 27, here it's quite old scheme, but 27, sorry, 27 genetic mutation, causative genetic mutation. And what you have to keep in mind is mostly this one, autosomal recessive inheritance, which is more frequent in UAE than in other countries due to the consanguinity, because as you know, there are many weddings between first degree relatives, cousins. So, so very interesting to understand when this mutation, how this mutation can trigger a neuropathology similar to that of sporadic PD. So you have several mechanisms in terms of pathophysiology. You have mostly the alpha-synuclein proteostasis, which is perturbed. And you have also degradation of this alpha-synuclein here through the ubiquitin proteasome system and through the lysosomal autophagy system, which are also disrupt actually. And on top of that, you have also the participation of neuron inflammation, of mitochondrial dysfunction and oxidative stress that finally lead to Lewy body, intracellular Lewy bodies, but also cell death. So what has also been assumed quite recently, maybe less than 10 years ago, that the propagation of the pathology could be prion-like actually, like you have in a prion disease, like in Creutzfeldt-Jakob disease, for example. And so you could imagine, again, with BRAC and with BRAC stages, that when you meet up, when you have a genetic susceptibility, I mean, risk factors, I'm talking about sporadic Parkinson disease, not hereditary Parkinson disease. When you have a genetic susceptibility that prevents you to have a good detox system for in your neurons, actually, and if you assume that the dopaminergic neurons are very sensitive to toxics, so let's assume that you meet up with an environmental toxic, and then you have some difficulties to detox your body and to detox your neuron, and then finally the pathology is starting. And it's not a coincidence if it's assumed that Parkinson disease does not start with tremor or slowness or rigidity, but Parkinson disease prodromal phase actually starts with constipation and olfaction loss. So it's not a coincidence, because you could assume that when you meet up with the environmental factor, with the toxics, with the pesticide, you smell it and you swallow it, actually. Reason why, first, symptoms are constipation and smell loss. And then with the prion-like propagation of alpha-synuclein, then it spreads up until it targets the substantia nigra pars compacta. And then after a couple of years, you have the first symptoms, motor symptoms related to the degeneration of pars compacta, which are tremor, rigidity, and slowness. And again, you have the first motor symptoms once you have 70 to 80% loss of the dopaminergic neurons in the pars compacta, which means that there is a compensatory mechanism very, 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 for a very long time before you cannot compensate the dopaminergic loss, and you present with the first motor symptoms. That again, first symptoms of PD are non-motor symptoms, constipation, again, and depression, and we're going to come back on it later on. So a key point for the understanding of focal therapies such as cell replacement therapy and neuromodulation, for example, deep brain stimulation, is to understand the motor circuit pathophysiology. So here you have dopaminergic loss in the substantia nigra pars compacta, and it leads at the end by overactivity of the subthalamic nucleus and overactivity of globus pallidus externus. So it means that you have to put an electrode here. If you put an electrode here, a deep brain stimulation in the subthalamic nucleus, you are going to reduce the overactivity of the STN. You are going to improve the motor symptoms. And for the replacement therapy, for example, brainstem transplant or fetal cell transplant, the goal is to add some dopaminergic neurons inside the striatum to compensate the deficit of dopamine that is supposed to be produced in the substantia nigra pars compacta and to be released here in the striatum. So this is important to understand how it works. So now, what about the diagnosis, the screening, and the prevention? So the clinical diagnosis and the natural history of PD, actually, PD is still diagnosed purely clinically. You don't have any...
Will be considered well for us.
You have early onset of Parkinson disease here, not early onset, sorry, initial phase. And here you have late phase. So here you have a mild pill rolling tremor on the right side. And here, of course, it's a very, very late stage where you have a very severe akinesia and bradykinesia. So here, just to show you that the key clinical marker of Parkinson's disease is rest tremor by opposition to postural tremor. So again, Parkinsonism is defined by bradykinesia. It means slowing in the repetitive alternative movements, such as tapping, opening of hand, or pronation supination like this. And on top of this bradykinesia, you must have a real rigidity that you test like this, actually, and you have balance and walking difficulties, and you have the tremor. But the mandatory criteria is slowness, bradykinesia. Now, here you can see that, again, you have preclinical, and preclinical is very difficult to detect You have prodromal, and here you start to have constipation, you have hyposmia, you have depression, you have urinary dysfunction, and then you have the manifest stage, actually, and you do the diagnosis once you have the bradykinesia, the motor symptoms. But each time you meet up with a patient who have Parkinsonism, you have to ask him, okay, before you started to have your tremor, your slowness, your stiffness, your walking difficulties, what about your constipation? What about your sleep? What about your smell? What about, did you have an history of depression? Because all this is prodromal non-motor symptoms of Parkinson's disease, and it's supportive of the diagnosis of Parkinson's disease. And here you can see that once you diagnose Parkinson's disease, of course, above this line, above this horizontal line, you have all the motor symptoms. But under, you have the non-motor symptoms, actually, and you have many, many non-motor symptoms. And actually, the non-motor symptoms are much more important and impact much more quality of life than motor symptoms. This is a Parkinson's iceberg. Everybody knows about tremor, rigidity, akinesia, postural disturbances. But again, keep in mind that this is a systemic disease with many, many, many non-motor symptoms. And we can quite deal easily with motor symptoms. We have many treatments because motor symptoms are mostly related to dopaminergic lesions, but non-motor symptoms are mostly related to non-dopaminergic lesions, and reason why you have much more difficulties to deal with non-motor symptoms. So the diagnosis test, forget CSF and blood test, it doesn't help actually. It's very inconsistent. But you have, of course, the clinical criteria. You can be helped, for example, with a smell test like UPSIT. You have imaging that can help you, and you have also genetics, but most of the time you do not do genetics. Imaging is very interesting because, for example, here you have a DAT scan. DAT scan is an imaging of the dopamine transporter. Here in UAE, the only place you have DAT scan is Cleveland Clinic. Here you have normal people. Here you have Parkinson's disease patient. Actually, you have a Parkinson's disease patient with loss of dopamine in the striatum, actually. Problem with that scan is it can only tell you that you have loss of dopamine. But what is important to keep in mind that it's not because you have a loss of dopamine that it's Parkinson's disease. It can also be what we call atypical Parkinsonism. And when I come back, on the diagnosis criteria here, you can see that when you have to put a diagnosis of Parkinson's disease, you have, of course, the Parkinsonism. Of course, you have DOPA responsivity, which is a must, mandatory. But you also have to have a patient that do not present any, who does not present any red flag. Red flag is, for example, early onset of fall, severe cognitive impairment, early severe cognitive impairment. You can have cognitive impairment in Parkinson's disease, but it should be late. You can have severe walking difficulties with falls in Parkinson's disease, but it should occur very, very late. Otherwise, it's considered as red flags. And when you have some red flags, it could be atypical Parkinsonism. So again, Parkinson's disease and atypical Parkinsonism, such as progressive supranuclear palsy or multiple system atrophy or corticobasal degeneration, all share dopaminergic lesion. But how, in this case, how are you going to differentiate the different Parkinsonism? It's, of course, with MRI and with red flags. Red flags, clinical red flags, but also with an MRI. And on the MRI, you have some specific abnormalities that can help you to differentiate Parkinson's disease from atypical Parkinsonism. And you have to keep in mind that the MRI, the structural MRI in Parkinson's disease is normal. When it's not normal, and I'm going not to get into the details of the abnormalities seen in atypical Parkinsonism, but when it's not normal, it's not Parkinson, it's something else. Genetic testing is unlikely helpful, actually, because, again, it's not the most common cause of Parkinson's disease. I mean, hereditary Parkinson's disease is not the most frequent one. 90 to 95% of Parkinson's disease are sporadic. It means that there is no causative mutation. You just have some susceptibility genes actually what give you a fragility, a neuron fragility to detox your body from the toxics actually. So sometimes genetic testing can be helpful just in case of early onset of Parkinson's disease. I mean, if you have a patient, especially in UAE, that starts Parkinsonism before the age of 40, it can be worthwhile to do a genetic testing because genetic testing can give you a diagnosis, and most of the time it's autosomal recessive subtype because of the consanguinity. And it's going to support, of course, to give you a diagnosis, but concretely from a therapeutic perspective, it will not help you at all, actually, because actually doesn't make any difference for the treatment. But you could provide your patient a genetic counseling for the family. So now, how to define at-risk individuals on prodromal disease? As I told you, actually, you have many prodromal signs like constipation, depression, anosmia, anxiety, or sleep behavior disorder. So now you have more and more some algorithm actually that try to define which patients are at risk actually for Parkinson's disease. Knowing that for the present time, we don't have any disease modifier treatment that could be helpful before the manifest phase, before the patient starts the motor symptoms, treatment that could slow down the progression of the disease. Currently, it does not exist. But once it will be on the market, we need to be ready. And to be ready, it means to be in capability to identify very, very early onset Parkinson's disease before the onset of motor symptoms. And you have, again, some non-motor symptoms and some many risk factors and prodromal markers that try to be included in some special algorithm. It's not yet in the clinical practice. Just here to underline that here you have, when you have polysomnography proven REM sleep behavioral disorders, you know, REM sleep behavioral disorders is patients who do some nightmares and very nightmares with very severe agitation. And most of the time, the patient comes at your clinic with Parkinsonism, and his wife has, if they share the same bed, his wife presents with some traumatic lesion actually, because sometimes she's going to tell you, sometimes my husband has some severe nightmares and he's shouting and he's hitting me during the nightmares. This is consistent with REM sleep behavioral disorders. And when you have somebody who presents to you with this kind of disorder, even if he's not presenting with signs of Parkinson's disease, his risk of developing later a Parkinson's disease is increased by 130%. So now the management. So management, you have mostly a compensation of levodopa, actually, of dopamine deficiency with levodopa, cinemet, with COMT inhibitors, with Stalevo, with monoamine oxidase B inhibitors, with rasagiline, actually, and with also dopamine agonists like Cifrol or pramipexole or rotigondin. All this is available in UAE, actually. You have also now safinamide, but it's mostly for patients with advanced PD, actually. So usually when you have the gold standard now is definitely, you can start with dopaminergic agonist, but definitely L-Dopa is still the gold standard. So I recommend you, when you have a patient starting Parkinson's disease, when you have established a diagnosis of Parkinson's disease, first of all, hi, sir, do you have any impact of your Parkinsonism on your quality of life or not? If he tells you that it does not impact his quality of life, you don't need to treat, actually, because all these treatments are purely symptomatic treatments, actually, which aim to compensate the dopaminergic loss. There is no disease-modifying treatment, so there is no urgency to treat. Only treat when there is an impact of the Parkinsonism on the patient's quality of life. In this case, you decide to treat with mostly dopaminergic agonist in young patients, but it's not absolutely mandatory. If you have a severe Parkinsonism in a young patient, very young patient, dopamine agonist will not be enough, and you should better start with levodopa like Cinemet. But you can also start dopamine agonist in case you have a mild to moderate Parkinsonism in a young patient. In older patients, start with levodopa most of the time. Then you know that after a couple of years of using levodopa, you have what we call levodopa fluctuations and levodopa induced dyskinesia. This is dyskinesia. This is abnormal involuntary movements that are associated with intake of levodopa. And here, actually, you have patient on a roller coaster at this stage. This stage is called advanced stage, actually. And in this advanced stage, you have patient who is not continuously covered by his tablet of Cinemet, for example. He used to take only 3 times a day. Now he has what we call a wearing off effect, which is an end of dose effect. And he comes to see you and he tells you, doctor, initially, when you gave me 1 tablet every 3 times a day, I was covered for the full day. My Parkinsonism was improved the full day all along. But now I take my first tablet at 6 a.m. and then at 11, I feel that the signs of Parkinsonism come back again. And it's time for me I'm anxious to take my tablet of 12. So this is called motor fluctuation, and it defines advanced Parkinson disease. Here, okay, I'm going to move forward. And beside this motor fluctuation, you have also what we just saw in the video, which are dyskinesia, which can be really debilitating. So when you have this advanced Parkinson disease, it's time to fragment the dose. You give several times Cinemet a day instead of just 3 or 4 times. You give it, for example, every 3 hours. You can combine Cinemet to COMT inhibitors. It's called Stalevo. So it's just cooking. You can also combine all this with dopamine agonists like Cifrol or pramipexole, and you can also combine it with safenamide, which is Xadago, actually. So keep in mind that once the patient enters the advanced stage, you can combine every treatment, every dopaminergic treatment. You can combine Stalevo with Cinemet, with Cifrol, with Xadago, with everything, actually. It's just cooking. So I don't have any specific rule for that. But what is also interesting, so yes, this is just a focus on dopamine agonists, because you have just to be very careful with dopamine agonists like rotigotine, Nupro, Cifrol, Cifrol or Rekip, actually, because you can have what we call impulse control disorders. For example, here is Sue, the lab that got him hooked on gambling and sex with ropinirole. Oh, he has mutilated and killed about 15 cats under the effect of drugs and against Parkinson. So, of course, it's extreme cases, but you have to keep in mind that when you put a patient under rotigotine, Nupro, or Cifrol or Rekip, you have to warn him, please be careful in case you have more sex libido, more feeling shopping or gambling or things like that. It could be related to dopaminergic agonists, and you have to tell me so that I can adapt the treatment. Besides all the dopaminergic pharmacological targets, you have also non-dopaminergic pharmacological targets that can target also that can treat motor symptoms. I'm not going to get into the details, but you have many non-dopaminergic approaches that can also help to treat the motor symptoms. By the way, you can email me a message if you want my slides, because of course I'm quite quick and I cannot cover all the details of the slides. You have also non-dopaminergic pharmacological targets for non-motor symptoms, and here you have a list of all the non-motor symptoms and all the different approaches, all the treatments you can use according to the non-motor symptoms. For example, for dementia, you have rivastigmine patch, like in Alzheimer's disease. And of course, what is also very important now in advanced Parkinson disease is what we call the device-aided therapy. Neuromodulation with deep brain stimulation, but also apomorphine pump or duodopa pump, and very soon subcutaneous levodopa pump. So here you have a patient who have an electrode in the STN and the stimulator is on. And then okay, we disconnect the stimulator, and very rapidly, actually, all the motor symptoms come back with a severe tremor, and the patient starts to be very, very anxious and to have some very important mood disorders. It was, of course, only for the purpose of the video. And now, okay, we switch on again the stimulator, and then again, all the motor symptoms are perfectly controlled again by the deep brain stimulation. So I will finish by this point. So the exercise-based treatment, it's a non-pharmacological approach, but it's very, very important. It's not only physiotherapy, because of course patients need physiotherapy and overall rehabilitation, but it's exercise, intensive exercise. Tell your patient every day, try to do some intensive exercise, at least 30 minutes per day. It can be fast walking. Why is it important? Because so far, it's the only therapeutic approach that have proven that it could slow down the progression of the disease. So ask your patient to move, and to move intensively every day, at least 30 minutes. It's the only way to slow down the progression of the disease. So in conclusion, we face now a kind of pandemic of Parkinson's disease for the reason I explained you. Parkinson's disease is not only a neuropsychiatric disorder, it's also a systemic disease that can affect many, many, many things beside motor function. Non-pharmacological treatment is a key point, like I show you with some exercises at home. Of course, you can be helped, and you are helped with the medications, and especially the dopaminergic medications. And also, a matter of hope is we have many promising approaches for disease modifying. Gene therapy is about to be launched, and repair therapies with also, for example, cell replacement with stem cell therapy. It's not yet a standard of care, but it's going to be a standard of care in a couple of years, probably. Thank you so much for your attention.